The main studies to date in GvHD have targeted. The main studies with fecal microbiota transplantation and microbiota-based interventions, the GvHD, have targeted steroid-resistant acute GvHD. Now, this is a tough-to-treat population with high rates of mortality, and there are a lot of barriers, actually, in giving these patients microbiota interventions. For instance, many of these patients are on antibiotics. Another sort of a barrier is that now that ruxolitinib is approved, then giving a fecal microbiota transplantation in a later line really reduces the likelihood of its success because patients have been exposed to so many treatments. So I think that as we go forward, the shift for studying fecal microbiota transplantation should be more on the prevention side. There is another study, again from Boston, from De Philippe, where they gave a fecal microbiota transplantation with capsules at time of engraftment with the aim of increasing diversity of the microbiome. And we don't know, obviously, this was a single arm study. We don't know whether it prevents or not or mitigates the risk of GvHD, but that's sort of a first step towards assessing the utility of fecal microbiota transplantation for prevention of graft-versus-host disease. Obviously, we need to randomize patients and do that in a controlled fashion. But I think that is likely the future of fecal microbiota interventions. Another sort of way to incorporate fecal microbiota transplantation is in combination, meaning that if we do have a patient with graft-versus-host disease, so we should hit him, quote unquote, or hit GvHD in several fronts, including the immunosuppressive front, but also giving FMT concomitantly. So I think that also increases the probability that fecal microbiota transplantation would improve response. The third, I would say, avenue for intervention or improvement is actually trying to develop more rationally or uniform microbiota intervention products, meaning that we control the microbial population in the microbiota or a microbiota product, whether it's a compound of probiotics or whether similar to what is MAT is doing, the company, and where they have a sort of pooled stool product where you can control the quality and the composition of the bacteria in the product. And that would allow, I think, for more reproducible results in microbiota interventions, because I think fecal microbiota transplant obviously has a lot of variability, both because of the way we administer it, whether it's with capsules or through another duodenal tube or a colonoscopy, etc., and also by the way we prepare the product. So we need more uniformity in generating the product and administering it in order to really derive conclusion about the utility of a fecal microbiota transplantation in prevention and treatment of graft-versus-host disease.